Hello, I'm Alex Abbott. I'm one of the primary care sports medicine doctors at Stanford Children's. I'm excited to speak with you today about triaging patients, which is a topic that has relevance in virtually every healthcare setting and can especially help athletic trainers to make your practice more objective on the sideline and in the training room. Today we'll start with some general background about triaging and what that actually means, and then we'll apply these principles to some high-yield specific patient complaints that often apply to athletes. We should also have some time for questions at the end. We'll start with an important term, disposition. This essentially means, where does my patient belong? Oh, the places a patient can go. Though our casual training room and sideline environment might be relaxing and fun places for your athletes, when an athlete complains about something like pain or an injury, they become a patient, and your first thoughts might reflect, what is the worst case scenario here with this new complaint? Is what they are presenting with potentially life-threatening? If so, then they're in the wrong place at the sideline or the emergency or the treatment room, and they need your help to get them to where they need to go. If someone has an emergency that can't wait until the parent comes and gets them and takes them somewhere else, 911 or sideline EMS should be mobilized to help them. If a patient needs to be seen soon but isn't in a life-threatening scenario, often private transport is sufficient to get them to an acute care setting. For acute care or immediate care, patients can present to an emergency room or to an urgent care in general. You should think about your pharmacy's minute clinic as the model for what an urgent care is to help contrast between an emergency room and an urgent care. This minute clinic can address wounds without significant bleeding. They can have a doctor check somebody out to determine what their needs might be. They can get x-rays and they can provide medicines and some DME. But if that doctor in the minute clinic, they do a checkout and they determine that there's more significant issues that might need something like an IV, blood tests, or advanced imaging, then an emergency room is more appropriate. If someone doesn't need acute or same-day care, then they might be better suited for a clinic visit. The primary care sports medicine doctor or the patient's pediatrician are going to be the clinics that you think about for non-musculoskeletal issues for the pediatrician. When you're deciding whether somebody needs an urgent clinic visit or a routine one, you should consider whether someone could potentially get worse in 3 to 5 days. That would be when they're most likely able to be seen for an urgent visit. But if they can't wait that long, then you think about acute care settings. Lastly, many patients can manage their complaints at home with things like rest, hydration, over-the-counter medications. This does count as a disposition option and one that you might consider. A patient's disposition and their triage needs are not always instinctual, obvious, or apparent. This picture is a screenshot from one of the board exams that physicians take. It's a computer-based simulation where patient complaints are presented, and then you have to decide what tests they need, how quickly they need them, before you make their diagnosis and then decide their treatment plans. You can see the user in this screenshot inputting what tests they want for the patient, but also make note of the option on the top right, change location. In these patient scenarios, sometimes you're in a hospital, emergency room, or an outpatient clinic. If your patient has something that can be treated at home, but you're making them go to an emergency room, then you lose points for their disposition. If you order a test that needs to be done in an emergency room, but you don't identify my patient isn't there right now, then you're wasting time on the examination that you're taking while that test that you ordered is not being completed. It's just sitting there because they're not in the right spot. The examination doesn't prompt you, hey, the patient can't get a head CT done in this clinic, or hey, do you think that they can leave the hospital since they're just taking Tylenol right now? The athletic trainers may not have the simulation examination as part of their training, but athletic trainers are often the very first person that a patient sees to make a decision, is my patient where they need to be? So we'll give these themes some specific examples. We'll talk about musculoskeletal injuries first. If someone complains about something like ankle or knee pain, deciding whether it's potentially a fracture is a good first step. Significant swelling, bruising, inability to use the affected extremity normally should make you wish that you had x-ray vision or the appropriate DME. Often, a lack of appropriate DME is the only reason that somebody has to go to an urgent care or an acute care setting. Patients shouldn't be asked to go by crutches if they can't weight bear normally. And if someone needs an x-ray, they need acute care to evaluate for fracture and then determine their immobilization needs. If you can splint a patient, that often helps significantly, but they still should have a same-day evaluation in an acute care setting. Someone should go to an ED instead of an urgent care if there's any concern for a neurovascular compromise, a wound near the injury, a deformity, or if pain is severe and doesn't seem like it would be addressed with just over-the-counter medications. On the right, you can see that the angry and swollen joints that make you nervous about fracture, but one of them is just a fracture with this tiny wound and not significant swelling, deformity, or bruising. This picture is to just illustrate how subtle an open fracture can be. If you identify an open fracture and you triage it appropriately, that can be extremely beneficial to your patient. If there is an apparent deformity or there's concern for neurovascular compromise, if you're worried about an open fracture, those all should present to an emergency room. If you assess a deformity, but you don't have any of those other red flag symptoms, so you're assessing a displaced fracture or a dislocated joint, the reduction prior to transport can be crucial for the health of that patient. Whether it's you as the trained athletic trainer or an EMS, that depends on your comfort and your knowledge of how to do that specific reduction. If someone's able to use their extremity, they don't have significant pain, then you might consider an urgent outpatient appointment. So these would be your cases of it's a bad sprain, but it could be a fracture. I'm not really sure, but they're not having issues where they need crutches or a boot, and I don't have any red flag concerns. For head injuries, I illustrated this sort of crude spectrum of differential for contusion, concussion, or intracranial injury to help estimate your triage needs for head trauma. Contusions would be head injuries that don't have concussion symptoms, and these patients might be instructed to monitor for symptoms at home and return to sports as tolerated. Use of your initial concussion testing for head traumas would help you decide if we should start the return to sport protocol instead. The red flags of your sideline assessment, especially for intracranial injury, prognosticate the likelihood for brain bleeds and help you to identify at the very beginning of your evaluation on the SCAT-6 and many of our concussion evaluations is the first thing that you're looking at to decide if we need to stop the rest of our evaluation and get them to a higher level of care. Many emergency medicine providers use the following criteria to triage patients for a likelihood of serious head and neck injuries, which might require CT scans or C-spine precautions. PCARN, the Pediatric Emergency Care Applied Research Network, applied a triage score to children and adolescents that's been validated for triage and is frequently used in emergency settings. The PCARN uses GCS scoring, mental status or consciousness, presence of vomiting, severe mechanisms or severe headaches, and then bruising around the eyes, ears, or runny noses to add points in favor of a very concerning injury. For children who are vomiting, adolescents playing football on the sideline, 2 vomits buys you a trip to the ED typically. I also included for your reference the Nexus criteria, which is the National Emergency X-ray Utilization Study, and they developed criterion for head CTs and for C-spine precautions. You might note that the head CT criteria is not for children when you use Nexus and includes age over 65 as a potential risk factor, which might apply to referees and to parents at your events. The most common reasons to triage someone to the ED on the sideline in general might be things like loss of consciousness, even if it's transient. So if a patient has a head injury and they have a knockout, they should present for acute care for observation. You might think about vomiting, like we talked about, and then midline spine tenderness. If you're not concerned about paraspinal strain, but you're pressing right on the middle of someone's spine and they're complaining of pain, those are all very concerning symptoms. There's an app called MD Calc that has these tools that you can click through on your phone and estimate risks. It's a free app and it has the Nexus and PCARN scales. But in general, if you're pulling out your phone to start adding up points, the patient probably would benefit from acute care evaluation and observation. On this slide, I illustrated a similar crude spectrum to our head injury spectrum for complaints of chest pain. Chest pain that's associated with trauma, you think about contusions, fractures, or cardiopulmonary issues such as commotio cordis or pneumothorax. If you're not familiar with these terms, commotio cordis is a rare injury where an object or a person strikes someone's chest directly over the heart, and it can cause an arrhythmia that requires resuscitation. A pneumothorax can happen when something like a rib fracture or a piercing object like a javelin or something like that pokes the lungs and needs needle decompression and other more acute care. Thinking about chest pain in terms of your differential like this can be really helpful for deciding a patient's needs. Without trauma, a patient might have costochondritis, a stress fracture rather than an acute fracture with trauma, or some other problem with their heart or lungs that doesn't include commotio cordis or pneumothorax. Red flags for the things on the right side of the spectrum might include things like shortness of breath, someone describing pain on the left side of their chest and radiating into the arm or jaw, abdominal pain for atypical chest pain concerns, and then dizziness and some other things that are more systemic. Concerns for infections would be there with chest pain coupled with things like fevers or upper respiratory symptoms. And then your green flags, things that you're hoping you find out about, mild costochondritis kind of things would be if your pain is relatively mild, the absence of any of those scary, more heart and lung symptoms. And then if there's reproducible chest pain with palpation. So if you can press on a spot on the chest to reproduce that pain. Examples of a patient's disposition for traumatic and atraumatic chest pain from the left to right would be home, clinic, and the emergency room. So that helps you kind of keep things objective and organized. Finally, we'll apply these principles to patients describing neck and back pain. Red flags relate to a history of trauma, midline tenderness, neurosymptoms or radicular symptoms, we also call them, progressive worsening, and limping or other abnormalities with somebody's gait. Red flags for clinic sound like chronic, atraumatic, no neurosymptoms or radicular symptoms. So an example of back pain complaint that needs acute care would be something like a patient was deadlifting and he was tackled in the gym and now his toes are tingling and it also hurts when I press on the bony part. Those kind of patients should go to an emergency room. We touched kind of on the tip of the iceberg of a lot of complicated topics, things that people specialize in and train for years to understand. So just touching on these things without giving you a full knowledge base of all of these can make triaging feel overwhelming. How do I know what commotio cordis looks like or how to manage it if I'm just hearing about this for the first time from Dr. Abbott? However, you don't have to be a concussion expert. You don't have to know how to read an EKG or place a needle for a pneumothorax. You can identify, I don't have what I need to help, and that is significantly helping the patient. That helps a patient also way more than trying to get by with your inadequate resources or your limited knowledge base. Athletic trainers have a scope of practice that is different than physicians, nurses, MAs, emergency room doctors, etc. Just because your knowledge base is different doesn't mean it's inadequate. You are able to still triage patients, and being the first point of care and the person that the athletes trust the most is a crucial part of their sports medicine team. If you think about a patient's needs in terms of a grocery list of possibilities, that's what we call our differential diagnosis. That can help you triage a little bit more objectively. Taking these hypotheticals and sort of talking them out with the people around you, whether it's patients, parents, coaches, that can help you communicate your decisions transparently. And then it can also inspire those around you to help you or coordinate things. And it can help improve a patient's compliance or adherence to your triage recommendations. So you can get better buy-in if you're talking about what you're thinking about objectively instead of making decisions and letting people around you think that you're making decisions either based on your emotions or the pressures around you, things like that. If you're talking out the way that we talked about in this presentation, that can inspire confidence in your decisions and help gather a team around you to help you. Once you make a triage decision and a recommendation, you should stick with it if you've made that final decision. If you get pushback, you should talk that out as well. So you might feel pressured by somebody around you that you're being too careful, too dramatic by recommending a higher level of care than what people are hoping for. But you might also feel irresponsible if a patient starts worsening and they're in the wrong environment, or if we have bad outcomes and you were pressured by somebody telling you, I don't really want to go to the emergency room. Keeping those biases and your social pressures at bay is a lot easier when you address them explicitly and you try to think about disposition needs objectively. You might say something like, I know you don't want to go to the emergency room, but you're telling me that it hurts too much to put weight on your leg, and I need you to at least be able to walk to the car, but I don't have crutches for you. That's a objective sort of way to take what the patient's concerns are and turn them into a recommendation that might improve the adherence, rather than I don't like how your leg looks, or I'm nervous about this, or something like that. Explaining why can help people kind of get on the same page as you. You might, for chest pain, you might say something like, I know you're worried about a heart attack, but it's reassuring that your pain is reproduced when I push right here and that your breathing is normal. Perhaps if someone listened to your heart with a stethoscope, that would be helpful. Those kind of statements you can use to sort of explain whether you're being conservative and recommending acute care, or you're reassuring a patient that their disposition needs might be suited at home. It goes both ways. Finally, my last point on this slide is to ask for help when you need it. So you should use resources like these slides that I compiled for you guys with those spectrums that we talked about, or your other clinical measurement tools like the MD Calc things we talked about, and your concussion evaluations and things like that. Those are really important to help organize your thoughts and make things objective. And like I said, the more objective you are, the more confidence you can inspire in your patients and the other stakeholders and the team, and help kind of get everyone to rally around your recommendations.